gives me a great pleasure to present one of the myeloma leaders in the world, Prof. Mohamad Mohty. He is well known, and I don't need to give a long introduction about him. He is a professor of medicine and hematology at St. Anthony Hospital. He the former leader for the EBMT, and he's the current chairman of acute leukemia working party of EBMT. He has published more than 700 peer-reviewed articles in multiple fields of hematology. So without any further delay, Prof. Mohty, the floor is yours.
Thank you very much for the very, very kind introduction. I really appreciate. Masa al-khair wa assalamu alaikum jami'an. As usual, it is a great pleasure and an honor to be part of your wonderful activities, and it is amazing to see the high level of this educational congress and the more than 4,000 participants, even if we are already late evening. So you already heard a lot about multiple myeloma, and maybe I'm at the end because I've been asked to wrap it up a little bit and say how multiple myeloma should be treated in 2022. And all my colleagues before me gave really lovely presentations. So I will try to be quite focused on a few, I would say, key issues. These are my disclosures. As it is the case, treatment of transplant eligible patient, because we divide myeloma frontline, transplant eligible, non-transplant eligible, and elderly. And I'm sure everybody is aware of this EHA-ESMO clinical practice guidelines, which are very, very practical. And when it comes to induction, actually prior to transplant, the recommendation is about VRD, bortezomib, lenalidomide, dexamethasone, or daratumumab VTD, bortezomib, thalidomide, dexamethasone, plus daratumumab. However, I would kindly draw your attention that the level of recommendation for VRD is 2B, whereas for DARA VTD, it's 1A. And this is why, for instance, DARA VTD is already approved by EMA, by the FDA, and is widely used, while VRD, for instance, is not approved everywhere, although it's a common regimen. So if DARA VTD is level 1A, the next question is, why can't we replace thalidomide by lenalidomide? And that brings us to DARA VRD, because that would be really the Rolls-Royce of induction, maybe. And we are very grateful to this phase 2 trial, randomized trial, Griffin trial, which was published in Blood a couple of years ago. And we had an update about the results during the last ASH meeting. It's relatively straightforward. It's either daratumumab VRD versus VRD. And to make a long story short, the trial was really positive, and there is a clear advantage for the quadruplet induction. And actually, if you focus on stringent CR or more than CR, actually the quadruplet DARA VRD is going to win at any time point you consider during the course of the disease. And the deepest responses are the ones occurring after 2 years of maintenance therapy. So you can appreciate that, for instance, here the maintenance is in the DARA VRD arm with DARA lenalidomide, but I'll speak about maintenance in 1 second. And the good news compared to the initial publication is now with longer follow-up, we can already see that the curves are now separating in favor of DARA VRD. And this is quite amazing because we have almost 90% PFS at 3 years. And I think Dr. Fahad and all the colleagues attending remember our medical school when we've been told that the overall survival of myeloma was 3 years. And now we're talking about 90% PFS at 3 years. And that brings me to the topic of the issue of MRD. And this has been extensively, I think, discussed previously by Dr. Joshua Richter, who really mentioned and commented the master trial. And you know, well, if DARA-VRD is great, why not replacing bortezomib with carfilzomib? And that gives you DARA-KRD. But to be very simple, because this has been discussed, actually, this is another proof that the quadruplet, the robust quadruplet induction followed by transplant is allowing actually to achieve very, very good outcome. And the other thing is that this NGS MRD adapted therapy proved to be feasible in the majority of the patient. And it also shows the benefit of transplant in the high-risk multiple myeloma patient. And actually, we have also data about the value of MRD with DARA-VTD. And what is really important, and that's echo the previous message from the colleagues and the nice discussion that took over before I jumped in, is that you really need to achieve a deep response rate. And this is about achieving MRD negativity immediately after induction, because if you see these pink curves, the group of patients who are MRD negative immediately and then remains MRD negative are actually the patient who will enjoy the best survival. So in summary, for us today, what we do every day, our standard of care is DARA-VRD for everybody receiving induction and is transplant eligible. This is clearly a major advance in terms of induction. You may remember we started with VAD, we moved to VD, then VTD, VRD, and now we are DARA-VRD, like, you know, the R-SHOP, which has been discussed also in before the myeloma session, I think during the lymphoma session that I followed carefully. What about the non-transplant eligible patient? Well, here the recommendation level 1A is about daratumumab, lenalidomide, dexamethasone to everybody. And I have seen a patient in my clinics this week who is 93-year-old and has been receiving DARA-RD now since almost 2 years with excellent tolerance. And you are very well aware of the results of this MAIA trial, long-term follow-up showing even an overall survival advantage. And this is quite amazing, because it means if you are treating today a patient who is 70 years old with myeloma frontline with DARA-RD, you are able to achieve roughly 6 years, 5 to 6 years of PFS and 7 years maybe of median OS. So this patient will go and can receive the treatment up to age 76 or 77. Then at time of relapse, this patient may receive another treatment for another 2 or 3 years. And actually, you have now achieved the life expectancy of such patient at birth in the Kingdom of Saudi Arabia. So you can see the revolution which is really ongoing now in the field of myeloma. But then I sometimes, especially when it comes to the elderly, I hear some colleagues telling, well, you should not use all your magic bullets immediately. You should leave them until the end, etc., etc. Why don't we start with RD and then add daratumumab later on? I don't think it's a good option. And there was at the last ASH meeting a very nice study from Dr. Fonseca and the Mayo Clinic in Arizona, who compared different regimens, RD, VRD, and DARA-RD, to look into the optimal sequence. And the conclusion was that among these sequences, DARA-RD in first line produced the best overall survival rate. So for me, it's clear that all patients, without any exception, should be able to receive DARA-Lendex. Of course, we can discuss the value of bortezomib in some patients, but definitely DARA-Revdex is the standard of care. So now, in the frontline setting, I think we have the quadruplet induction prior to transplant. We have DARA-RD. Some patients will continue to relapse. It will occur late. So what's new? You heard already also very nicely about the different options, and Dr. Joshua showed some nice slides about IKEMA. We have the Candor trial with daratumumab, carfilzomib, dexamethasone, the Apollo trial with daratumumab, pomalidomide, dexamethasone, and we have, of course, the Icaria trial with isatuximab, pomalidomide, dexamethasone. However, the revolution for the next couple of years will come from the bispecific antibodies. And if you look at the last ASH meeting, actually, there was at least 7 or 8 different bispecific antibodies, T-cell engagers, being presented. The majority were directed against BCMA, but you had 2 candidates, 2 agents, which were directed against other antigens, different non-BCMA, namely cevostamab and talquetamab. I will show you the result of the teclistamab bispecific antibody, because this is the most advanced one, which has been now filed to regulatory authorities and likely to arrive within the next few months into the daily clinic. And thanks to this phase 1/2 trial called Majestic, 165 patients, you can see the median age 64, but it goes up to age 84. So even the very old patient can receive them. And these patients had extramedullary plasmacytomas. They had a bone marrow plasma cells infiltration more than 60% in 11%, 26% high risk cytogenetics. They were all triple class exposed. 70% were pentadrug exposed. So they have received everything available in multiple myeloma, and they were 90% almost refractory to the last line of therapy. Despite this, what is really amazing is that you have a 62% overall response rate. These are patients who are supposed to be in palliative care in general in our institutions. If you have failed already, for instance, 6 lines of prior therapies, 5 lines of prior therapies, and it goes to 14, in theory, it's very, very hard. And palliative care is the option. Here, we're talking about 62% of objective response rate, including 29% more than CR, 21% stringent CR. So it's very impressive. And you have even a proportion of patients who can achieve MRD negativity, which is quite unbelievable, you know, looking into the status of these patients. And all of this can happen with an excellent safety profile, because no patient required any teclistamab dose reduction, and only 1 patient discontinued because of an adenoviral pneumonia. So, and the other good news is that, as you know, bispecific antibodies may give CRS, cytokine release syndrome, but here actually there is no severe CRS. So in my opinion, these bispecific antibodies will be widely used even in small centers. The other bispecific antibody I wanted to mention is talquetamab, because if you have used an antibody against BCMA and the patient has relapsed, you would like to switch gears and look into another antigen. So this one is targeting, and you need to become familiar with it because you will hear a lot about it. The results are really very good. The target is GPCR5D, and the study is called Monumental. And similar to the Majestic trial, it has included a lot of patients. And again, you can see that 90% or 72% of these patients failed a prior transplant. The median prior lines was 6 and 5 up to 17, you know, depending on the cohort. And these patients were refractory to almost everything, you know, pentadrug exposed 80% in this cohort. So really heavily pretreated population. But despite this, we have 66 to 70% of an overall response, including 10% stringent CR. So again, very impressive results, especially if you look to the triple class refractory or to the pentadrug refractory patient. Of course, the numbers are small, but you know, there is no smoke without fire or fire without smoke. And I think these results look brilliant. What about safety? Well, safety is excellent. And you have here, and we need to learn how to deal with it, because then the patient will complain about it, some skin lesions and nails, because actually this antigen GPC-R5D is expressed on in the skin and the nails and on the hair, you know, of the skin. So very good results. And last but not least, the revolution in myeloma will continue because now we have 2 approved CAR T cells. So actually last year we had the ide-cel product, which was approved, but on the 1st of March, which means 5 days ago, you had the approval of cilta-cel, this product. And this is a quite unique construct with CAR T cell, because it is a BCMA targeting CAR T cell, but the BCMA catching domain can target 2 different epitopes simultaneously. So it's like you're shooting the malignant plasma cell from 2 directions. So you would guess that the potency will be very good. And indeed, the approval was achieved thanks to this so-called CARTITUDE-1 trial, phase 1b/2 trial, which included 97 patients, median age 61, up to 78. So you can give CAR T cells in very old patients. And 20% had plasmacytomas, 24% had high-risk cytogenetics, and the median lines of prior therapy was 6 up to 18. So try to count a patient who received 18 lines of therapy. I'm still counting them, you know, I couldn't find all of them. But you can see that 66%, 2/3 of the patients received more than 5 lines of therapy. And of course, majority were triple class refractory or penta-drug refractory. 99% were refractory to the last line of therapy. So again, a very heavily pretreated population, almost going to palliative care. Despite this, the objective response rate was 98%, including 82% of stringent CR. And you can achieve this in less than 1 month. So single shot treatment with these CAR T cells, very revolutionary. In 1 month, you achieve 80% stringent CR. And this is reflected by the progression-free survival and overall survival curves. Because remember, the ide-cel product, the PFS was 9 months. Here we're talking about a median PFS, which is not reached yet. And if you consider the population with stringent CR, which is the majority of the patient, actually the 2-year PFS is 71%. And looking into the overall survival at 2 years, you have 74%. And these are patients who failed to everything. So watch out for this CAR T cell when it will arrive very soon, because it's a true revolution in the field. So how to choose between CAR T cells and bispecific? The efficacy is very good for both. The safety is manageable. I didn't discuss it, but actually, in contrast to lymphoma or to ALL, the use of CAR T cells is relatively safe in multiple myeloma, very rare side effects. Of course, the problem is that with bispecific, they are off the shelf. You can start the treatment in 1 hour, whereas with the CAR T cell, you need to wait for a few weeks. In CAR T cells, you need some bridging, not necessary with bispecific. You need lymphodepletion. You don't need lymphodepletion with bispecific. Of course, a CAR T cell is a single shot treatment, and then it allows the patient to have a treatment-free interval, maybe for 1, 2, or 3 years. Whereas with the bispecific, you may need hospitalization and you may need to repeat the treatment. But the revolution in multiple myeloma will not stop with bispecific, will not stop with CAR T cells, because if you look at the last ASH meeting, it is really amazing to see that there are still now a new generation of new classes of active agent being developed. And believe it or not, now we're also trying to combine other agents we use in hematology, for instance, JAK2 inhibitors, with the immune therapies we already use in multiple myeloma. And while we have just got the approval of cilta-cel by FDA this week, actually, there are people already designing and developing a new CAR T-cell construct. So the future of multiple myeloma look bright, and I'm convinced that in the next 5 to 6 years, we will be able to cure a significant proportion of these patients. And this is really very, very good news. So with this, I'd like to thank you all for your attention. And of course, I'm more than happy to take your question. Shukran jazeelan.
Okay, so thanks, Prof. Mohty, for this very comprehensive but to the point talk. As always, your message is always clear. So I have a comment. So now in 2022, you know, the good thing, we have so many excellent options, but you know, it's making, you know, any physician who deal with myeloma patients a bit puzzled with, you know, how things gonna be in the next few years, especially if you don't have the access to CAR T-cell or bispecific. And I'm saying that because either we like it or not, you know, monoclonal antibodies are moving to the front line, which makes it difficult in terms of what to do with the patient when the patient relapses. Most of the data we have now is with the use of monoclonal antibody in the relapse refractory setting. But now if we use it up front, we don't know, there is no clear data about how to sequence things. And if someone failed one monoclonal antibody with other monoclonal antibody will work or not. So these are some of the unanswered questions yet. And I think
I can comment on this. I think this is really a very, very relevant question, and I do thank you for raising this issue. I think you have to distinguish the fixed duration treatment with antibodies. And for instance, when you do induction with DARA VRD, for instance, prior to transplant, you use 4, 5, or 6 cycles maximum. And actually, you do not develop, the patient do not develop resistance to daratumumab. And in our hands, for these patients, at time of relapse, we re-challenge them with daratumumab-based combinations, whether carfilzomib, pomalidomide, lenalidomide, depending on the scenario. And I can assure you the results are absolutely excellent, and we don't have any issue. The problem may be an issue in case of the elderly population I mentioned, where if you have given daralendex continuously. But here I think, while you may be right that they will develop resistance, but I gave you the situation of the 70-year-old patient who will receive daralendex and have a median of PFS of 5 or 6 years. So I think it's time is your best ally in multiple myeloma. So I should not think what's going to happen in 5 or 6 years, because in 5 or 6 years, I will have many other options. I will have other antibodies. So just do the best treatment frontline, including monoclonal antibodies like daratumumab. So I think this is an important message because we hear it a lot. Now, then you raised a second issue, whether one monoclonal antibody can salvage another. Well, if we are talking about different targets, then obviously there's no problem. And I mentioned, for instance, for the bispecific, you can use teclistamab, you become resistant, you use talquetamab, or vice versa. I think what you are thinking between the lines is, for instance, the anti-CD38, because now we have 2 nice antibodies. The first to be approved was daratumumab, and recently we had isatuximab, which is also another anti-CD38 monoclonal antibody. Daratumumab is subcute, isatuximab is still IV, but I think at some point we'll have a subcute for isatuximab. For the time being, we do not have any data, I think, that could show that if you resisted to daratumumab, you can be salvaged with isatuximab or vice versa. But I must confess that in our hands, we continue to give antibodies. You know, I think, let me ask you, maybe give you an example. The patient in myeloma are always receiving dexamethasone. And actually, when they relapse, the next regimen includes dexamethasone. So how can you be sure they are not resistant already to dexamethasone? When you treat lymphoma, actually, you keep on giving rituximab. You give R-CHOP, then you give R-DHAP, R-ESHAP, R-ICE, etc., etc. So I'm not saying this is evidence-based, but this is empirical, in my opinion, because the expression, especially if the expression of the antigen is there, but we need more research to look to the mechanism of resistance to the CD38 pathway.
Thank you so much for this clarification. So now, if we look at the Cassiopeia trial, so they did another set of randomization where not everyone received daratumumab as a maintenance, and the study showed that mainly the patients who were not exposed to DARA as part of their induction, they got the benefit. So a patient who received DARA as part of their induction as a DARA VTD, no significant, I should say, improvement in their outcomes with the DARA maintenance. So do you think DARA as a maintenance should be given to everyone or to selected patients, or should we do it based on MRD, for example, or something like that?
No, again, thank you very much. This is really a very, very important question, and I think you have analyzed very carefully the Cassiopeia trial. So here I have a few comments. First of all, the Cassiopeia trial is an academic trial, and you have to put it in the context, because we're speaking about the results today, but actually I can assure you, we discussed the design of the Cassiopeia trial 6 or 7 years ago, and I'm part of the IFM, and we have our board meeting, and we discussed all this. And 7 years ago, actually, in France, we didn't have lenalidomide approved for maintenance. So they allowed that some patients could not receive maintenance. But what you're alluding, I think what we know from the Cassiopeia trial based on these results today with long-term follow-up is that, first of all, you need daratumumab at some point. You know, there's no questions, there's no debate. You need to give daratumumab to the patient, because, and even if they didn't receive it in the beginning, they will benefit from it later on. So that's one point. The other point from the trial is that for the first time, we have a proof of concept that you can give daratumumab maintenance, because this is the only trial where you have daratumumab maintenance after transplant. So you have a proof of concept that is, it can be given. However, I'm not saying it is already a standard of care. So in our hands, we don't give daratumumab single agent in replacement of lenalidomide. Today, the approved drug is lenalidomide. I think the future, and this is what you are alluding to, and there are studies and ongoing trials, we're waiting soon for the results, I think, where probably we will combine daratumumab and lenalidomide. And this is what we have in the Griffin trial. And from the Griffin trial, I'm convinced that now the future of maintenance is actually about doublet maintenance. And we have seen this in the Forte trial, for instance. They used carfilzomib lenalidomide. Of course, you don't want to use IV carfilzomib for maintenance, but daratumumab subcut plus lenalidomide is really very attractive, and we have a few patients receiving this.